This first session, we have our first international speaker with us for the session, The Future of Cannabis Medicine, Therapeutics and Research Issues. I would like to introduce our speaker, Associate Professor Antonio Vigano from McGill University Health Center. Associate Professor Antonio Vigano graduated Doctor of Medicine from Milan University, Italy, and Master of Science from the University of Alberta, Canada. Dr. Antonio is an attending physician at the Supportive and Palliative Care Division, McGill University Health Center, and is a pioneer in palliative care in Canada. He has held many prominent positions at McGill University, including Associate Professor of the Department of Oncology, Director of the Cancer Rehabilitation Program, Founder and Director of the McGill Nutrition and Performance Laboratory. He is also an expert on medical cannabis appointed by the Court of Quebec and co-director of the Biomedicine Axis of McGill Research Center for Cannabis. Ladies and gentlemen, please welcome Associate Professor Antonio Vigano.
Thank you very much for the nice introduction, the very welcoming hospitality. It's been a pleasure for me to be here for the first time in Asia, and I'm looking forward to working with you, and particularly with Professor Shriving, which I really thank for all the work that she did. So, first of all, I need to make some disclosure. And so here we are. I mean, we often collaborate with industry in order to realize our research agenda. But this has to be seen as a constructive relationship. And that has been so far my experience. So just to let you know where Canada is and where Quebec is, and Montreal, you see, is the most important city, and I work at the McGill University Health Center, about 1,300 beds capacity. So I would like to start to put this presentation under the blessing of Chiwok Arafat. He was the doctor of Buddha, Lord Buddha, and is considered the father of Thai medicine. Under his blessing, we will look at the following aspects. What are really the challenges right now for both clinical and research domain? What are really the way to overcome these challenges by looking at patient-driven clinical, educational, and research models? And we would like to end talking about personalized, translational, and integrated approach for medical cannabis in cancer patients, which seems to me really the way that you want to go through. What is the current scenario? Most of the time is a patient that comes to clinicians to ask for medicinal cannabis. And the first question that the clinician will ask himself, is medicinal cannabis available? And we will see that that is not the case in most countries around the world. So it's obvious that when you have this kind of request, you have to start, is this available? But here, like in Canada, will soon be available to clinicians, medicinal cannabis. And at that point, the question for all clinicians is, what are really the benefit I can expect from cannabis? And when we are talking about cancer patient, we also have the questions from patients, will cannabis help to cure my cancer? And in my experience, on 10 patients with whom I will start medical cannabis, 8 out of them, so 80% of them will ask about the potential role of cannabis as an anti-cancer treatment. So it's a very important question that we need to always keep in our mind. And the other aspects that is important is also what will be the side effects of cannabis. And when we talk about side effect, we talk about cannabis being a medication that is added to other medication that the patient is currently taking. So that's a very important question also that to answer, what is the safety profile of cannabis? And then the clinician, most of the time, will either recommend or not cannabis, but how we will see, unfortunately, most of the times, the clinician who is asked by the patient about medicinal cannabis is not the clinician who is able to actually prescribe medical cannabis. And this is a bit the experience that was surveyed in two areas, in two parts of the world, the United States of America and Australia. And as you can see, both for oncologists in the United States and for family practitioners, primarily in Australia, only 1/3 of the physicians interviewed were really aware or were really able to know what to do with medicinal cannabis, how to prescribe it, and so on. So why is this? The reasons are multiple, and obviously we will not be able to cover all these reasons, but at least we will start talking about the one that we can actually manage. First, regulatory restrictions or regulatory restriction. So these are very important, and we'll see and have determined so far the chances for medicinal cannabis to be studied and to be prescribed. It's obviously that there are many actually research gaps that needs to be filled. And what we need to understand is, so what? So how can we overcome these knowledge gaps? When there are big knowledge gaps, there is also limited training and educational opportunities, and that is very important. But what both our university and your university is doing is these kind of meetings. This is really the way to overcome this limited knowledge. And then there is an important social stigma. Even with patients with advanced cancer, particularly in patients who are of a certain age, the concept of starting medical cannabis is very, very difficult to accept. It's considered still a drug. It's considered still something that you cannot be addicted to, that you cannot stop, and that will bring bad consequences to the life of patients. You probably know that better than me because of your traditional medicine legacy, but cannabis is not new and has been used for many, many years. And, but only recently, cannabis has been identified as to what really is the mechanism of action. But despite this, its progression in terms of research was always hindered, was always slowed down by the fact that cannabis was classified as a dangerous, addictive substance. As for the United States, it's class 1 which include morphine, which include heroin, which include all medication that have sort of a bad stigma associated. Nevertheless, in 1964, 2 years actually I was born, Professor Mechlin identified the substance that was actually responsible for the effect of cannabis, called THC, and that substance was also able to be reproduced by some synthetic analog, which are not available in Thailand, but I will mention those for the sake of our completion. We also, after the discovery of a THC, discover the receptors. As you know, and pharmacology professor will confirm, sometimes is really not the substance that explain a mechanism of action, but it's really the receptors that is responsible for this mechanism of action. And then we had, in 2010, the first approval of a natural extract to be covered by the prontuary, the formulary, and in particular, the combination of extract of THC and CBD that were approved for use in MS spasticity as well as in cancer pain on moderate intensity. So that is very important because by this sort of recognition, in Canada we call DIN of drug information number, and through this number medication can be covered by a professional, so provincial or private insurance plan. So, and the amount of research has been also present or increased in PubMed. And as you can see, that has sort of marked the different steps in which, through which medicinal cannabis was actually studied and gradually introduced in our understanding about the role of this preparation. So the isolation of THC, the understanding about the biochemistry behind, including the receptors, the anandamide discovery, meaning anandamide is our natural THC, is what we call really endocannabinoid. So this also to say how important is to understand that it's not just a molecule itself or a combination of molecules I will see, but it's really the way that those molecules interact with our own system. This is similar to what happens for opioids. Okay, we also have some endogenous opioid that we produce. And then there was the legalization of medicinal cannabis in Canada, which didn't really span too many of research, but because again was primarily under the public pressure and not really driven by scientific observation. And then we have the nabiximol, as I mentioned before, Sativex, this extract of THC and CBD, which was approved for coverage. And now we are going through the exponential growth about legalization of medicinal cannabis, and with much more many more opportunities for research. Still, nowadays, if you look at the amount of publications regarding medicinal cannabis, is still quite limited as compared to the publication related to marijuana abuse or cannabis abuse. And that reflects also the still quite a prevalent understanding about cannabis, which is really not appropriate because relates rather to its strict use, to his recreational use, rather than its medicinal use. And the other thing that is also interesting to notice is that when we look at the amount of publication related to, for instance, cancer, trials for, to treat pain, and we see the discrepancy, the disproportion among what was published around opiates and what thus far has been published around cannabis. And obviously, the number of patients that have been included in clinical trials very, very limited. So why all this has happened, as I was mentioning before, is because of regulatory issues, and that particularly in the United States, as this cannabis was classified as a class 1, okay, and so there was really no incentive for doing research or for looking at a possible product to use in the clinical practice. And so that has slowed down quite a bit the possibility of randomized controlled trial. And really what we have seen is that on one hand, the policy makers were stopped, were not really considering cannabis, but on the other hand, there was a public pressure to have cannabis included in the treatments available, okay? But what this situation has generated, as you can see, first thing, we didn't have really safety report about cannabis. There was a confusion about recreational use versus medical use. And we really didn't know about the full effect of cannabis. So cannabis is really, as we will see, is not a single molecule, as you probably know, but is a compound of many, at least 150 different molecules that are responsible for the effect of cannabis, which is called entourage. It's a French word to say a team sort of effect, okay, of all these molecules were on the patients. We didn't have clear understanding about indication. We still don't have it, but I will present some evidence regarding that. And no standardization about therapeutic dose, and also quite a variety of standards for research, for industry-related research around medical cannabis. So again, something very different from another type of molecules. So what is currently the situation, and as was introduced by the president of this university, is Thailand is really the first country in Southeast Asia to have legalized the medical use. And you see Canada has also legalized the non-medical or recreational use, but most of other places are really right now focusing on just the medical use. But as you can see, it's still quite not frequent, not really present in most part of the world, the possibility of prescribing medical cannabis. So what now talking about what should we really do in this condition? What has been recommended to overcome this lack of evidence? And again, the lack of evidence, which is not just an issue in terms of regulatory bodies, but is also an issue in terms of complexity in studying medical cannabis. So phase 4 studies have been recommended. As you know, in order to have a medication approved for coverage in most of the of the countries of the world, you need phase 3 studies, randomized controlled trial on a large scale type, whether multicenter or whether with a high number of patients. But these, again, are not easily reproducible for cannabis. So we are looking at phase 4, which is normally a post-marketing studies. And what we are looking at is not really the efficacy, which will only be proven by a randomized controlled trial, but we are looking at effectiveness. So what really cannabis will do in the real world, okay? And the advantage of doing these studies is a very high external validity, meaning when you're looking at a medication in the real world, then you may extrapolate in a much easier way the observation to another situation, another sample of patient, another place in the world, because those information are not really coming from a randomized controlled trial, which is, yes, a higher internal validity, meaning that, for instance, the outcomes are better adjusted for confounding factors, but the generalizability of the outcome of a randomized controlled trial are very limited, okay? So still we have a technique to overcome the limited internal validity. And we have, for instance, the possibility of identifying group of patients that will more or less take cannabis under the same impression, under the same expectations. And this is called a clinical equipoise, okay? So we, for those patients, the expectation regarding cannabis are already adjusted for by selecting a population which is homogeneous in these sort of aspects. And then we have a propensity score matching, meaning that we will look at patients that present with similar characteristics. And those similar characteristics will make, you know, the possibility of presence of other confounding factors less important in studying medicinal cannabis. So, but one aspect is very important. Observational studies should be studied and should be planned as we would plan a randomized controlled trial. So we'll have to have those parameters that are important to design a randomized clinical trial present in the same way when we look at observational studies. And you can see, you know, the different aspects. So it's not a fishing expedition that we want to do. We want really to understand through an observational study the effect of cannabis both in terms of safety and in terms of effectiveness, but under specific design characteristics for the study. So what then are the characteristics of this post-marketing and observational design? They are not interventional, and that may simplify quite a bit the design. They do not meet an NIH definition of a clinical trial, which obviously, you know, is randomized controlled trial, double-blind, and so forth. And they are not designed to focus on a specific product, but rather at the use of a product that can be generalized, can be used in the clinical practice. So most of randomized controlled trial, again, are looking at a single molecule, very standardized concentration, very standardized regimen, but this is not applicable for medicinal cannabis. Not applicable, why? Because it's such a personalized type of medicine that we will not be able to say that a certain concentration works in a certain patient in the same way that in another patient or in a different concentration. So that is what is very important to provide through these observational studies information to clinicians, policymakers, consumers, in order to make decisions that are based on science rather than anecdotal information or misinformation. One aspect, for instance, when we look at our reality is medicinal cannabis as an anti-cancer treatment. Okay, so this is, at this point, is still anecdotal information. I wouldn't say it's misinformation, but it could become misinformation in, when it is sort of used over the internet. My watch has stopped. I thought it was going, but so I'm not sure, okay, time-wise. So I wanted to talk with you about the Quebec Cannabis Registry being an example of this type of observational studies. First of all, why we are talking about this project? Because of specific situation in Canada. So since 1999, medicinal cannabis has been available in Canada, but has been available under very, very evolving type of regulation. And despite this availability, the different collèges de médecins, the different professional orders in Canada didn't really recognize it as a medical products, but they sort of recognized that primarily as an experimental type of approach. And that is what the Collège de Médecins, which is our professional order, College of Physicians and Surgeons in Quebec, really required back in 2014 in order to initiate medical cannabis under specific guidelines. So they told physicians, if you want to start medical cannabis, you can do only it under a research protocol. Okay, so that has obviously has put some restriction on the ability of physicians to prescribe medical cannabis, but has also created an opportunity to start a registry. And by the way, this registry is now has been implemented in England and in France. So we are just starting to do this. We started back in 2014. Okay, so so thanks to Dr. Mark Ware, we could have a framework of a pharmacovigilance type of study where clinicians could recruit patients and monitor these patients through a specific protocol. That is the type of philosophy behind regulated observational studies. So not just like a case series, or not just like a otherwise retrospective data collection, but a prospective data collection under specific like design characteristics. So, so that was the objective of the Quebec Cannabis Registry. We were really looking at potential risk or benefit as pharmacovigilance studies. And we wanted also to create a resource for future studies. And that is what we are doing actually, because we completed the data collection and now we are looking at analyzing this data and start knowledge translation process. So what kind of data we collected were clinical data, obviously regarding the patient diagnosis. We know that cannabis can be prescribed not just for oncology patients, but a lot of other indications, as we'll see. Symptom profile is obviously a way for us to understand, the relation between cannabis and specific symptoms, concomitant medication, very important aspects. We also want to understand if there was a relation between specific strain and the outcomes that we were measuring. In terms of patient-reported outcomes, we are looking at brief pain inventory, the Edmonton System Assessment System, and the quality of life measure. And very important, so we were looking at adverse event. So here are the tools that we used. Probably you are familiar with the first two, but I'm not sure if you're familiar with the quality of life tool that was implemented, that was recently also validated for the Thai people, or in the Thai language. So I cannot tell you what is written there, but I can tell you that we are looking at 5 domain of quality of life, 5 dimension, and 5 level of impact of the outcome of a specific intervention on the outcome. So that has been the way that was planned. The studies where we were in a baseline collection of information was a screening process. So this patient had to be naive to medicinal cannabis. So we're not looking at patients that were not starting. And there was a consent process, there was a data collection, and there was an indication of a treatment plan, so the type of cannabis recommended, along with the assessment of the patient the quality of life measurement. And then we had a follow-up that was lasting up to 2 years, and so you can see that at the frequency, specific frequency, we have been collecting this information, and again in terms of outcomes and in terms of side effects. And then we would also have a long observational continuation, but again, that was not systematic as for the first 2 years. All the data were collected centrally, okay, and the adverse event were also communicated to Health Canada. We were looking at adverse event at least moderate to severe, not mild, because that would have been difficult to collect in a systematic fashion. So this has been the number of physicians who participated in the study. As you can see, it's very important the provincial representation. When you want to do an observational study, it's important to be as representative of a certain place as possible. And so those will be, the physician information, and that will be, the distribution of this physician. And as you can see, family medicine is the place where more of these patients, either with oncology diagnosis or with chronic conditions, chronic pain, are seen in Quebec and more or less in Canada as well. But certainly we have a representation of anesthesiologists, psychiatrists, geriatric medicine, okay? And this is the enrollment that was, achieved during the study that lasted between 2014 and 2018, so 4 years. 15 to October 2018, so three years. Now, these are the representation of this population. As you can see, pain is really the area where most use is made of cannabis, and followed by mood disorders, primarily anxiety, very important aspects that affects quite a number of patients, And it's not necessarily well managed with conventional approaches. Oncology, followed right after, neurological disorder like multiple sclerosis, other degenerative condition, gastroenterology, and other. So actually here is a bit better simplified, and again, low back pain being and fibromyalgia and arthritis being the most represented diagnosis. And then, when we look at mood disorder, again, anxiety and insomnia being very, very, very well represented, okay? These are the oncology diagnoses. I would say that this is really, may not be necessarily representative, okay? But just to give you a sample of what these patients looks like. So, very interesting to see what has been the adjustment of the type of prescription during follow-up. And as you can see, it really didn't change too much across the follow-ups, okay? So whatever was used to start, was used, continued to be used during the follow-up. Of interest, patient using inhalation, smoke and vape were quite significantly represented, during this follow-up. But, gradually, the patient were also using more oil, oral, and so that has been something that we kind of see also in another so this is very interesting to see how the use of inhalation has changed with the introduction of edibles, okay, or oral products, primarily cannabis oil. And as you can see, the oil has took over, the other type of administration. And 80% of our patients right now are really using edible products. So the inhalation, which is also the form that most patients who are naive to cannabis think they will use, is in fact really not used or not recommended. Just wanted to go back, also to look a bit at the trend in the type of cannabis used. We call the ratio THC and CBD as the chemovars, for cannabis. And, at least 27% of the patient were authorized to take at least 2 products, okay? But that increases over the follow-up, meaning when the patient becomes more expert in the use of cannabis, they can be proposed different alternatives for the use of cannabis. And here you can see a bit the distribution. Interestingly enough, which kind of could be one point of discussion, is that here in Thailand, you don't really have available CBD-rich products, which are available in Canada and are pretty much used most of the times. But as you can see here, there is a good use of THC and balanced product, which will be the one that you will be using, or either THC-rich or sort of one-to-one and balanced product. So that's important to say that even, if the CBD may not be available to you, but you still have, about 70% of your patient, you can still use effectively the either balanced or THC-rich products. So again, these are studies that allow us to understand what happens in the real world to patients taking cannabinoid products. So we have seen that already, and again, the oral formulation. We didn't really have information, exact information on the dose that patients have used. This is a challenging information to quantify, but we had an information about how much these patients were authorized to buy. So in Canada, we have regulation which says that the clinician will have to specify how many grams of dry equivalent cannabis the patient can use, okay? And that is based the authorization. Within that dose, then patient can use a different proportion of either oral or edible products like oils or dry products for inhalation. So you can see that, we rarely went above 2 grams per day, which is not a big dose. It's not a big dose of dry equivalent. I'm not sure if we'll have time, but I would like then to speak about how to quantify the use of cannabis, which is a very important aspect to understand, again, what is the amount of medication that the patient is taking. So now the important information, what about adverse effect? And this is to me very, very important, to see that, we had essentially only 3.6% of patients experiencing moderate to severe adverse event, okay? And only 30% of these were serious cases. Serious meaning requiring hospitalization, requiring, major intervention. So all the rest of these were essentially mild side effects, which didn't really require, most of the case, stopping the treatment, okay? And these are, side effects that you may find with whatever medication that you're using, even aspirin or many other medications, and that could be even much worse than what we see here, like non-steroid anti-inflammatory steroid medication. So, and here again, when we look at the association, okay, between serious adverse event and, the possibility, likelihood that the product caused the side effects, as you can see, only, the mild to, only these first 2 classes were really involved in these side effects. But if you look at only 26 cases over, over almost 3,000 patients, if you look at aspirin or anti-inflammatory, that number will be much higher than this one. The deaths were not really related to cannabis. Both patients died of myocardial infarction, but the first patient was only using CBD products, and the other patient have ceased use of cannabis a year before he died. Okay, so very, very sort of limited really association of cannabis with serious adverse events and adverse events that, yes, may have required hospitalization, but they were not necessarily, and again, I see quite at times difficult to associate a causal effect. We can talk more about these like in a moment. And by the way, if you have any questions, I like a bit of an interactive, so please raise your hands, ask, and we can make it a bit less tedious, this presentation, okay? So let's look at now the outcomes, the pain outcomes, okay? So this is like the different type of pains recorded in the brief pain inventory. So worst pain with 24 hours, average pain, and current pain at visit. And you can see that there was, most of the relief was after 3 months at the first follow-up. And then there was a stabilization of the effect. So these patients were in general, the effect were maintained over time, okay? And most of our patients will report anyhow that the pain may not have changed in type of severity, like intensity, in this case, like on a scale 0 to 10. But patients will report most of the times that they can cope much better with their symptoms. And so this now is the impact of pain on different modality. And again, the most relief is observed after 3 months, general activity, mood, walking ability, normal work. And you see, we start from 6 and we go down at times to 4 or to 3. This is a 30% improvement, which is considered like both clinical and statistical valid. So this is the ESAs with different symptoms: pain, tiredness, drowsiness. The most impact is, I would say, well-being as well as fatigue, and that is also related to the possibility of a patient to stop certain medications that may sort of cause side effects. And we'll talk more about that. So this is a scale, a 0 to 10, and as you can see, there is a constant improvement of quality of life over time, okay? And here we are talking about still a significant number of patients followed after more than 1 year, okay? Of course, we have many lots to follow up, particularly in the cancer patient because they die. And so that to say, that the quality of life again, went to about 4 to about almost 6.5, in terms of a 0 to 10 scale or 0 to 100. So what obviously are the potential limitations of these studies? Then, it's not randomized. We had a lot of loss to follow up. We're still working a bit more on quantifying the medication use, but this is coming up. And safety data may be underreported because the mild effects were at times not reported, okay? But you will see that even the serious side effects were really not important. How representative is this sample is always a question. And at times when we look at combining this data, this information, we may lose, the effect on specific symptoms, okay? Which by just aggregating all patients, we lose focus of maybe 1 or 2 indications that for which we could be more specific. And we'll see that in this second part of a publication. What are the strengths? And as you can see, large number of patients, standard follow-up. Most of the times, the studies that you will find in the literature are related to the use of cannabis for 2 weeks at the most, 3 weeks, which is quite different than the use that is mostly done, which is a chronic use, which can be months, several months. Okay, so that is important. What this study told us that when patients are prescribed cannabis by a health practitioner, physicians and nurses, the medical cannabis is quite safe. And again, the effect of cannabis can be seen in different domains. So what we are looking in terms of future research, I was mentioned already, precision medicine approach. Through these studies, we can understand association between outcomes and different indication or different characteristics of a patient. Essentially, when we talk about cannabis, and we see it afterwards as well, we are talking about 3 entities: the patient, the disease, and the type of cannabis. And it's really to try to understand what is the relation among these three entities is how we can really build a precision or personalized model for cannabis. We have used patient-driven clinical, educational, and research models, and we'll see that in a moment. And but we are working towards, again, a personalized, translational, integrated approach for medical cannabis in cancer patients. So any question thus far?
Thank you,
Okay, so-
Professor.
yes.
Are there any questions from the audience? So if there are any questions, please raise your hand and we can pass you the microphone. While we're waiting for some questions from the audience, I'd
Yes,
like
we can
to
have-
have a question of my own.
Yes.
So from your wonderful lecture, it seems that the research regarding the medicinal use of cannabis are rather limited right now. So what do you think is the reason that there are not so many researchers in this regard?
Just to understand clearly,
Yes.
what you're saying, what you're asking is, what are the? I didn't understand that very well.
Yeah,
sorry.
so what can we do to help increase the research
Yes.
regarding medical use of cannabis?
That is
Yes.
what we are seeing now.
Yes.
We are going to see. One is, first was this large observational study, as an example or way in which we can acquire data for policymakers, for instance. Okay, so we know it's safe, it looks safe. Okay, we know that patients benefit from it, and so these are already important information. We didn't have those information before, And then let's move on with the rest of the presentation.
Yes, okay.
By the way, I have until noon for.
Yes, you have until noon.
Perfect.
Yes.
So we'll try to make it a bit more, like interactive, because I know it might be a bit tedious. So let's look at this patient-driven model. This is really Sante Cannabis models. And the way that we are suggesting now to organize our clinical work. Essentially, the most important aspect is to have the data collection or observational study embedded in the clinical work. So we do our clinical work thanks to a structured data collection. And we sort of have the possibility then of using this information that we collect primarily for the patient benefit, but also to inform more and more ourselves and others about these outcomes. So we have the presence of a research assistant which work with a research nurse, okay, to make sure that this part is well accomplished in terms of proper data collection. Then all this information is evaluated by a physician who works in combination with a cannabis educator. And many times the cannabis educator is also the research nurse, or is the nurse coordinator, okay, in order to make a plan, and this plan is communicated to the referring physician that will be then integrating this information in the treatment plan for that patient. So and again, we have this information where we get this data, we use this data to assess patient, caregivers and family, and we feed this information to clinicians, but also to possibilities of, favoring clinical research. For instance, you have a wonderful pharmacist that is working with you, And the pharmacist could really get the data about the patient that are treated with specific products through a specific protocols that we will show you. And that information can then feed research and quality improvement of our work. So what are then the research opportunities? As you can see, we have a lot to learn about different product type, and we see what we mean by product types, different ways, route of administration. We will understand what characterize the effect of cannabis, also based on this important aspect that terpene and cannabinoids that are present in the natural cannabis. And we will sort of better determine what are the difference between using synthetic products and natural extracts. So we'll be able to gather more evidence on what are really the effect of cannabis, the effect that again can just measure through scales, but can also be measured through a specific assessment or interview of a patient, and we'll see then more in in the upcoming presentation, and obviously we'll have more evidence to dispel myth. And very, very important is also to understand how cannabis can reduce the medication burden, and so provide again policymakers with information that will sort of hopefully push towards a coverage of medicinal cannabis. Medicinal cannabis, natural products in Canada, for instance, is still not covered by the government or by insurance, private insurance plans. So that is a big issue, a big limitation for the patient access. So this is a bit the patient-driven model, and but what about integrating cannabis in the care of our patients, particularly the oncology patients? As you know, the disease trajectory is characterized by different stages. There is a stage of diagnosis, there is a stage of cancer treatment, which can lead to a stable cancer, or a situation where there is a continuous evolution of a cancer, which again can go to more a palliative care versus a time where the cancer may go into remission. And as you can see, we can, implement cannabis at all these different levels. It's important to underline the role of cannabis in palliative care, but not just palliative care. We'll see that our concept is really supportive care, meaning care of a patient that starts from the very time of diagnosis, and sometimes even before diagnosis, okay? So, so for instance, we have a program included in our cancer rehabilitation program, which is called prehabilitation. Right now, it's run primarily on a research base. It's not so patients are only recruited into protocols for prehabilitation, but the concept is that we need to think at cannabis right at the time of diagnosis and even before then. Why? Patient experience anxiety, pain. There are certain cancer, and you are very familiar because I think you are center of reference for cholangiocarcinoma, if I understood correctly, or liver cancer. These patients present already with symptoms, and those symptoms, cancer symptoms, are the way in which they are diagnosed about their condition. So there is already there a role for cannabis to be started for lack of appetite, for pain, anxiety, insomnia. Okay, so that is where we can help there is an aspect of the existential suffering related to a cancer diagnosis. And there is the impact of cannabis on functional and nutritional status. Let's remember that function and nutrition for these patients are very important in order for them to go through cancer treatments. If their functional and nutritional status is not good to start, they will have more complications during their treatment. So we have to think about cannabis also in a preventive fashion, okay? What kind of research we can do at this level? Qualitative type of research. Particularly for cannabis, we need to understand what is the experience of patients by taking cannabis in relation to their way to cope with a disease. And we would like to start collecting specific information about these patients, for instance, genetic makeup, okay, and potentially also, but also at the time of diagnosis of a tumor markers or other things that we could use for potential matching, you know, specific type of cannabis for specific type of disease in specific type of patient. And we want to do a quantitative research. Obviously, we want to look at, you know, understanding how the cannabis can have a role on those symptoms. We have a cancer rehabilitation program in which we are recruiting patients. We have also a cancer pain clinic that is actively involved in this patient recruitment. So then we have a treatment phase, you know, when the patient goes through treatment and have all the side effects, including from treatment as well as from the cancer. And it's so important to maintain, again, the functional nutritional status. Again, we are looking at this type of research, and we are looking at, you know, the medical cannabis clinic to start, you know, playing an important role for patient follow-up, but again, to continue that patient-driven model of care. We have then a sort of an advanced phase, an evolution of a cancer, a sort of the beginning of a terminal phase, okay? And here, of course, all the concept of palliative care and the concept that cannabis becomes integrated in the conventional care, not as an alternative to that. And we have, you know, the potential to explore potential effect of cannabis on type of diseases which seems not to respond anymore to conventional treatment, okay? So that is also an important aspect that, you know, we could look into. And then, you know, in cancer survivors, very important to understand that even if the patient is disease-free, he may still have important consequences from the treatment that he received. And sometimes, not sometimes, but in general, we've been comparing information coming from cancer survivors as compared to cancer patients who have advanced disease. They are pretty similar in terms of nutritional and functional characteristics. So even though the first group is disease-free as compared to the other that has advanced disease. So very important, and we have also situations which are very, very difficult to treat with conventional treatments. For instance, graft versus host disease. Terrible consequences of this syndrome, which makes patients really suffer a lot with skin condition, gastrointestinal condition, really, really terrible. And that can only be essentially treated with a high dose of cortisone, and we know that high dose of cortisone have also a potential for a lot of side effects. So, and we have also peripheral neuropathy from, you know, treatments. So that aspects of, you know, patient that complains about pins and needles in their hand and feet, pain, particularly at night, and we don't really have very good medication. Even methadone or other medication, pregabalin, are really not completely effective. Sometimes they don't really do a lot. And cannabis can be a useful integration, okay, to consider, at least to help the patient to cope with these symptoms. And so again, cancer rehabilitation program, cancer pain clinic, medical cannabis clinic. So it's important to consider the medical cannabis clinic integrated in the rest of the service available in your hospital. And then the terminal phase, you know, the cachexia syndrome, the existential spiritual distress, important area to investigate and to consider for medical cannabis. So what we really want to do is to realize what I call, you know, personalized, translational, and integrated approach for medical cannabis for cancer patients. So you can see how many areas we can really work on. The first would be really to understand, is there a role for cannabis as an adjuvant for anti-cancer treatments? And again, you know, the possibility of a translational model, whether we can determine the response or the effect of different strains of cannabis on a specific type of tumor which is cultivated, you know, in experimental animals, and then identify a possible strain that would be then used with a patient, okay? And again, we have still a lot to learn, primarily with phase 1 study, but that is a line of research, and we need to sort of answer or give an answer to our patient that says, is cannabis possible for treating my cancer? At this point we say no, but we know that that is not the complete answer. We can, when we need, still to better understand the anti-cancer role of cannabis. We need to then combine or define products that have specific characteristics, okay? And this, the collaboration with the agricultural department is extremely important. Pharmacists, agricultural department, clinicians, really to identify which, you know, type of strain we could consider, for instance, initially for detecting or for understanding their anti-cancer role. So very important. And of course, genomics of the patient, genomics of cannabis, and potential genomics of cancer. Again, these three to combine through artificial intelligence, what, you know, are the factors that may sort of related to a clinical response to medical cannabis. We have the possibility again to study the long-term effect of cannabis. That has to be done through observational studies, where we have to determine, you know, all kind of characteristics for this intervention, and again, what clinically is relevant as compared to what we observe in a lab. Artificial intelligence again as a way to combine this information, you know, what product will work best in this patient for this condition. We still have to determine specific effect, for instance, for cancer pain. So we still need, you know, a phase 2 for 3 clinical trials, potentially using extracts versus the full strain of cannabis, which has many more variables, but these are still important variables to study. And the existential experience, very, very important, and also to understand the issues like treatment compliance and other things, and the effect of cannabis on well-being. Another important area is gender-based analysis. So how much is our gender influencing, you know, the effect of cannabis, and you know, what could be gender-related to the patient, gender-related difference in terms of diagnosis, and all these aspects of interaction. Very, very important health economic analysis to really understand what is then the impact of cannabis on healthcare cost for these patients. So that is why we created the McGill. It's not really the reason, but why we are part of the McGill Research Center for Cannabis. You can see the mission, and you can see that it's similar to what you are planning here. We go from plant to people to policy, okay, the 3P. And so how that we, how our goals or objectives to favor cutting-edge research on cannabis, to develop high-qualified researchers and clinicians, medicinal cannabis, and offer opportunities to knowledge translation and translational research, and in different domains. These are our three places, the McGill McDonald Agricultural Campus, downtown campus, and our hospital. These are the people involved in the McGill Research Center, free access, and 56 investigators spanning from plant to law. And when you look at the biomedical, we have a pharmacological domain, primarily in the preclinical domain thus far, which is different from what you have, which is very interesting. It's already a clinical evolution, which is very easy, make easier the collaboration with clinicians. We have a preclinical facility, and we have a clinical domain, that essentially is looking at developing this integrated model, okay, and primarily to again develop a patient-centric type of investigation with biobank, with integration of clinical data, with help with regulatory aspects of running these trials. So, so in summary, evidence-based approach is needed, but should be done differently than a formal randomized controlled trial. Has to be patient-driven, and we are suggesting a personalized, translational, and integrated approach to favor, research on medical cannabis. And these are the people that have been helping me in this particularly research-related domain, Quebec Cannabis Registry, and the research primarily in cancer patients. So that concludes the first part of my presentation. I wonder if at this point there are questions before I move to my next presentation.
Yes, there are a few questions from the audience.
Thank you very much for your presentation. It's very nice and very informative. I have questions about the quality control of the research. If we have no restriction of the accessibility of cannabis, such as from the private distributors, that we have no idea about the ratio of the CBD to THC, or the traditional medicine that come from the crude plant of the cannabis. This would affect the interpretation of the clinical outcomes of the patients, right? And some of the patients who lost the follow-up, maybe they not stop using the cannabis, but they find the easier way to buy the product from somewhere else. So how much the restriction of the distribution of the cannabis do you think we have to put in place to prevent that phenomenon? Thank you.
First and foremost, you have to involve health professionals. So you have to have a health professional participating to the clinical care of the patient and not them sending the patient somewhere else, okay? Or telling the patient, I don't know anything about this, I cannot help you. Because that is the first issue. This patient don't have any other alternative than going to sort of alternative resources or alternative sources of cannabis which are totally unregulated and which cannot be considered a medical approach. That is very important. The restrictions that were available in Canada had allowed us to have a high quality product which can be considered pharmaceutical grade. But where that doesn't exist, then we are talking about I don't know what, because you don't really have a reference. So that is a bit the trade-off. But I hope that in the future, government will be stimulated to support not only the research, but also the availability of cannabis, high-quality cannabis, to the patient. And I'm pretty sure that the cannabis at the end will cost less than many medications that are used that are almost not effective.
Just one quick question.
Yes.
Here. Just wondering, a lot of your unpublished data were done on the pain patient.
Yes.
And most of your research are uncontrolled. And we know that with chronic pain patients, there are a lot of psychological background or risk that coming with it. Without the control in chronic pain patients using this rather new intervention, would that prevent us from getting published or interpretation of the result? Thank you.
So sometimes it's a bit difficult to understand because there is a lot of noise, okay? But what you're asking is if our result will be published without a control, yes. So this is the fate of observational studies. So we don't have a placebo control. We know that cannabis can work in different ways, like could be more psychological, could be more like controlling the inflammation, for instance, with CBD-rich products. There are different ways. But through our approach to observational studies, which is not randomized controlled, we can still gather some information about the effectiveness of cannabis. And to me, right now, it's more important to understand if a certain intervention can help the patient instead of confirming how that intervention is helping the patient. You see what I mean? So that is a bit, how we are doing our research through registries. There might be some important aspects related to a randomized controlled trial, classical, but I would look that for just specific indication. Very, very sort of standardized and with a very, very simple model, primarily looking at extracts versus the natural products. Because the natural products, it's about 150 different molecules, okay? How can you control for all these molecules? But when you have an extract, like most of the studies that have been done so far that we'll present have been done on nabiximol, which is a spray that has, a balanced formulation THC CBD, about 2.5 milligram of THC with 2.7 of CBD each spray. That is a bit easier to study and potentially better for a clinical trials. But when you are looking at oils, products like available from naturally available, then to me the observational studies are more a better way to study the effectiveness.
Are there any more questions from the audience? Okay, so if there are not any questions at the moment. Okay, so maybe we can move on to the next topic.
Okay, so I will try to be a bit faster so that for the sake of time. And so just to be a bit more related to our focus which is oncology and palliative care. So again, some disclosures which now you are familiar with. And then again, Chiwok blessing our outline, which will be a quick review of the cannabis mechanism of action, some information about evidence for supporting palliative care and our recommendation. So I guess you are quite familiar with these, but we know that cannabis is used in many different forms, and it's primarily, we have hemp, which has less than 2% of THC, and the rest is cannabis. And these are produced in trichomes in the cannabis flowers and leaves. How it acts is through interacting with receptors. We know quite well the functioning of a CB1 receptors, which are primarily in the brain and the central nervous system. We still are debating what is the role of CB2 receptors. CB2, which is primarily involved in peripheral organs and in cells associated with the immune system. So we know that all this effective is mediated through the endocannabinoid system, which is involved in all these multi-system regulation, and that is where our system, which produces its own endocannabinoids, anandamides and 2-arachidonic glycerol, is then impacted through two kinds of primarily exogenous cannabinoids. One are the phytocannabinoids from the plants, and we have also synthetic cannabinoids, nabilon and dronabinol, both THC analog. But you don't have here nabilon, so we'll not talk very much about that. We know the properties primarily of THC, which are psychoactive, okay, and but have involved in many different domains, anti-inflammatory as well, particularly in AIDS patients, as I learned. They are the one that stimulate the appetite as compared to CBD, who doesn't really have any effect on the appetite. But for the rest, there is quite a bit of similarity between THC and CBD, except that CBD is not considered to be intoxicating or psychoactive. And We have also this distinction, which is sativa or indica, is not being really kosher according to the scientist, but is useful for clinicians to identify whether to use products during the day versus at night. And those sativa or indica effects are played primarily within the entourage effect, and the entourage are the synergistic effect of many compounds. Some of them are identified as other type of cannabinoids. We have non-cannabinoids, and we have terpene and flavonoids. And the terpene system is quite complex, as you can see, and in order to summarize a bit what are those effects, you can see that depending on the presence of these important terpenes, which are also considered essential oils, we may have different type of effects, which are important, again, in establishing the effect of a certain strain of cannabis, which again goes beyond the simple ratio between THC and CBD. There is quite a number of indications for cannabis, and we'll try to understand a bit more of the evidence supporting this indication. And we know that there are some side effects associated with THC and CBD, but most important are the side effects which are related to THC. And most of them are really because of a THC presence. Again, most common side effects can be dealt with adjustment of the dose of the product used, or modifying a bit the composition of a type of strain that can be used in the same way. So we have rare side effects. We have seen in our sort of a cohort of almost 3,000 patients how uncommon those side effects are if cannabis is prescribed or authorized by a healthcare professional. So if we go a bit in the literature, again, we are looking at observational study, and this has been the most important one, conducting in cancer patient, followed for over 6 months, and for each patient over a 2 years time, and you can see how this patient have improved over time with improvement of symptoms, primarily sleep problems, fatigue, anxiety and depression, and vomiting. Okay, so these are effects that are otherwise difficult to obtain with conventional treatment. And what we think the most important effect has been is really through the improvement of their quality of life, through the way that they could cope with their symptoms. So there was another study that was done, also in Israel, looking at 211 patients, and again, improvement in symptom related to anti-cancer treatment. And this is very important, as we have seen before, for patients who are undergoing treatment, not necessarily patients in palliative care. There was, some side effects, but not very important, and above all, they were really not causing suspension of a treatment, but rather adjustment or decrease. Again, I would like to propose some of our results, again from a cannabis registry, as you remember, and again, oncology was the third most important reason or diagnosis in this cohort, patient cohort. And you can see how little side effects were reported in cancer patients. So only 0.04% of a patient that we followed through the Quebec registry have, presence of adverse events, okay? So almost only 13 patients, okay, had experienced adverse events. And interestingly, none of these patients had any serious adverse event, okay? And the one that I already commented. I just would like to bring your attention to this, diagram. And of course, the follow-up, number of follow-ups, dropped significantly over time. So we know that is a limitation. But you can see, that again, the most improvement is it happens in the first 6 months of treatments, where we still have a good, percentage of follow-up, and then is maintained and even improves, over time. So, generally speaking, when we look at cancer patients, we look at symptoms becoming worse towards the end of their lives. And in this case, actually, we noticed that for the patient that survived, it was actually an improvement in the pain severity outcomes. And pain interference, again, from the brief pain inventory, we can see how, we're able to maintain a good symptom control and even improving it at the end of the treatments. And over time, these patients traveled in a better way than non-cancer patients. This to say that even with a disease which may become more symptomatic with evolution of its evolution, the cannabis was still able to achieve good pain control and pain relief. Again, we noticed that there was an improvement in pain relief over time. And again, we are limited because of a loss to follow-up samples. And now for the well-being, okay, still a sort of pretty stable effect. Here you can see that actually there was a worsening, probably in relation to the terminal phase. And this is the quality of life tool, okay, and you can see that even though we patients may be living longer and sort of maybe approaching more the terminal phase, we still have a sort of a positive trend for quality of life, effect of cannabis. So, what do we know about medical cannabis in palliative care? And certainly we know that palliative care is becoming more and more a needs for intervention, not just for cancer, but for other chronic conditions. We have been looking at a concept called terminal cancer syndrome. No matter what diagnosis the patient have, they will end up with presenting similar symptoms, primarily fatigue, anorexia, cachexia, pain. Okay, so those characterize the terminal phase. Now, we know that there is still a problem in determining the benefit of cannabis because of a lack of clinical data, and we are limited by absence of education. So what do we know in chronic neuropathic pain? We had a nice meta-analysis, 5 randomized controlled trial for inhaled cannabis, a total of 178 patients. There was like a limited time effect, but you know, that translated in 5 to 6 patients treated to have 1 patient improving for neuropathic pain. And again, the limitation of these studies were small number of study, small sample size, and short follow-up. We've been looking at chronic pain, neuropathic, and cancer. Again, 28 studies. That was in regard to chronic pain. There was a significant reduction in pain in at least 30%, greater for cannabinoids rather than placebo. And now these are, so this number include one trials with smoked and 7 trials on nabiximols. Again, that combination of THC and CBD. So what do we know from our experience? We have been looking at 60 patients. 31% of these patients had a THC CBD product, which will be a product that you will use, and another 44% have combined oral and inhaled therapy. We had a significant change in pain from baseline, greater than 1 on a scale 0 to 10, which is considered clinically relevant. We had a BPI improvement, and we have also an improvement in pain interference. So only 30% of a patient experience moderate side effects. I would say mild side effects rather than moderate, which, 30% included mild side effects, and 13.4 moderate side effects didn't require in discontinuation of treatment. And these were the most common side effects: drowsiness, dizziness, and dry mouth. Opioid-sparing effect, we have primarily studies on preclinical studies, only 9 clinical trials with 750 participants that were considered mostly low quality with inconclusive results. So this is still something that needs to be better studied. What we can say about cannabis and chemotherapy-induced nausea and vomiting, very important, the effect of THC. In Canada and North America, we have been using primarily synthetic products, being nabilon and dronabinol. And unfortunately, we don't have a lot of studies related to natural cannabis. We know that the synthetic works, and we know that anecdotally, patient may benefit from oil or from inhalation. We are looking at our sample size or our, to better determine these outcomes. Just about the time. So, anorexia and cachexia syndrome, we have so far studies that really didn't prove to be effective in cancer patients because the dose was very small. For instance, this study was one of the only one that used THC and natural THC versus THC plus CBD and versus placebo. But you will see the dose is what we normally use just to start the treatment. So you will see that not to be, that to be an important factor, the appropriate dosing. Improves taste and smell, food enjoyments, in these patients. So that is important. Now, we've done also our studies. Here you can see that our patients were able to maintain weight and improve appetite. A small sample. Again, overall, good tolerability with 27% of patients with mild side effects. We wonder how cannabis is able to improve appetite. We had recent evidence the way that it does it is through an hormone called ghrelin. Ghrelin is secreted in the brain and is secreted by the stomach, and is sort of works in different parts of the brain which are responsible for appetite, and also has different other effects like gastric motility and other things. And the THC primarily will help to increase the production of ghrelin and also to increase sensitivity of the brain areas who are responsible for appetite. I'm sorry that this is very small. I hope that you can see a bit, no, probably too small, but there are different parts of primarily the hypothalamus parts that are responsible for appetite increase. And we had done also another studies looking again at appetite in cancer patients, and you see an improvement over time, and this was done on over 35 patients. And so, cannabis and sleep problems, we have evidence again of THC product to help with sleep, sometimes having also positive effect on sleep apnea and apnea index. These studies have been now questioned a bit by the American Society of Respirology, in the sense that what the American Society of Respirology says is that you cannot use Nabilon to treat sleep apnea, okay? Nabilon, again, being a THC analog, but you can still use with caution Nabilon in association with CPAP, for instance, to improve the overall outcome in these patients. But again, they are demanding more studies about that. We know that THC in particular may be helpful to treat post-traumatic stress disorders, and that we know that have a big impact on sleep problems. And that is where, you know, many of our patients, even though are not classical patients undergoing a PTSD from war experiences or other things, but may still have this type of syndrome because of cancer treatment, for instance, or because of other bad experience in their lives. And that is where the THC can be working through a depersonalization that may sort of help with this anxiety-related sleep problem or PTSD-related sleep problem. Another aspects related to sleep problem is the presence of hot flashes, and in these particular studies there was, small dose of dronabinol. Again, dronabinol is a synthetic analog of THC that was helpful to treat nice sweats and hot flashes. What about the spiritual and existential suffering? Again, the emotional dissociation effect of cannabis may be very helpful particularly in patients in the terminal phase, or patients for whom it's very difficult to cope with their cancer diagnosis. And again, I would just go, we know that at this point in time we cannot recommend it for anti-cancer purposes, even though there are some preclinical evidence, but again, it's much different to say preclinical versus clinical. And so these are the indications that we may sort of consider for palliative and supportive care. Now, what we produce is this publication that is available free access, okay? So in this publication we go over the different challenges that patients have where, or the clinician have, not really patient, when we are trying to consider medical cannabis in oncology. And throughout our our common trajectory, we will really try to help you to understand how to deal with these challenges. And okay, so I guess that's basically it. Cannabis and endocannabinoid system restore equilibrium in the central nervous system. Evidence is already available on medical cannabis for supportive and palliative care. And the treatment, of course, needs to be personalized, and we'll see that in our future lectures in this workshop. So I guess this is basically it. But again, we will be able to go back to this indication, how to deal with adjustment of titration of the medicinal cannabis, and I'm very happy to get some question from you.
Thank you, Professor Antonio Vigano. Are there any questions from the audience? Yes, please. Do we have a microphone over here?
Thanks for your nice information. It seems like currently the evidence of medical cannabis is still lack of high-level evidence to support both effectiveness and the long side effect. So at this status or at this moment, how to communicate to clinicians or healthcare providers to accept the use of cannabis as treatment under the pressure of lack of evidence, because the professions of healthcare profession, we have been taught to practice based on the evidence. And now, like currently, we still get resistance from clinicians or healthcare providers because of its lack of evidence. Thank you.
Thanks to you. So, if I understand correctly, your question or comment in regards to the role of cannabis in terms of safety as well as complementary effect?
Not really. It's like based on the state of evidence, it's still lack of the high level of evidence to support either effectiveness or the safety. So at this status, how can we communicate to clinicians or healthcare providers to accept the use of cannabis, because most of patients or clients lovely or like feel like it's effectiveness to use it?
Yes, it's obvious that the only way to communicate with clinicians is through studies, through evidence, like through. Now, because there is not that evidence yet, what we need to sort of understand is that cannabis cannot be considered as a first-line treatment, okay, and should be given when the palliative and supportive care conventional intervention have been offered to our patients. So we know very well that if a patient comes and is constipated or is depressed or his pain is not controlled, we cannot rely on cannabis for any acute intervention. Cannabis, as you've seen, is, or you will see more, is very personalized process in which you need to understand what is the dose and what is the strain of cannabis that is working for that patient. So that takes time. That is something that you cannot not offer to a patient who is dying immediately, you know, who is in the terminal phase, because you need this patient to communicate with you on the effect of cannabis, okay? And for you to, it takes, you know, a few days to understand what is the dose that is working for this patient. But what you can talk with your colleague and say, look, right now, we don't have anything better to offer this patient. Why don't we consider medical cannabis? And so what I would like to see also as a clinician is that this patient was properly managed by the supportive and palliative care team before goes to start medical cannabis. I think this is probably one way to communicate with our colleagues. Obviously, when we publish those studies looking at, you know, opioid sparing effect, we'll see that a bit later. Decrease in medication use, better quality of life, okay, for this patient. Those will be the convincing arguments to provide your oncologist, your other, you know, colleagues. I think that would be the way.
Are there any more questions from the audience?
It's been a bit of a long presentation, back to back. We will have more opportunities to discuss about practical approaches in this afternoon and tomorrow. So stay tuned.
Okay, and the professor will be with us for today and also tomorrow, right? So if you have any other questions, you will have lots of opportunities to discuss with both of our experts here. So I'd like you to give another round of applause to Associate Professor Antonio for the wonderful lectures this morning.